Okay, when we talk about neonatal resuscitation, the first thing we probably need to know is when we should and when we shouldn't. These are kind of the commonly accepted reasons for not starting a resuscitation. This is out of the NRP manual. Typically, we should consider not starting resuscitation for any kid who weighs less than 500 grams. We should also consider it for any kid who's got trisomy 13 or 18. There's a consensus that if kids got congenital hydrocephalus, we may not start resuscitation. If the gestational age is less than 24 weeks, we generally don't start resuscitation. And finally, if the kid has fetal growth restriction, then we may not start resuscitation. So those are the first things you need to know when we talk about NRP, which are the patients who probably don't need resuscitation in the first place, which are the ones that are probably not viable. And those 5 patients are kind of classic examples of things that are typically not viable. Okay, when we talk about neonatal resuscitation algorithms, I would suspect that most of the people that are watching this video have been through NRP before, but just a quick review. When we very first have a child who's born, the big thing that we do right off the bat in the first 30 seconds is we suction out their airway, we dry them, we stimulate them, and we try and get them to essentially pick up on their own. If that doesn't work within a relatively short period of time, then what we're going to do is assess whether or not the kid is bradycardic or not. We usually say that bradycardia is anything less than 100 in a neonate. If the kid is got good respirations and the kid is not bradycardic, but the kid is cyanotic, then we usually put the kid on oxygen. In contrast, if the kid is bradycardic and the kid has an effective respiration, then the big thing we need to do for that patient is we need to bag that patient for about 30 seconds, and then we need to reassess. If we've seen an increase in the heart rate greater than about 60 or so, then we'll continue with the mechanical ventilation. If the heart rate continues to remain less than 60 despite 30 seconds of good effective bagging, then we need to start chest compressions and we need to reassess again in 30 seconds. If after 30 seconds we still haven't seen an increase in the heart rate greater than 60, then we need to start doing our advanced interventions, which would be things like intubation, giving the patient epinephrine, those types of things. Okay, now what happens after you do your initial resuscitation? Let's say you work through your NRP algorithm and you get the patient stabilized. They've now got a heart rate that's greater than 100. They're looking a little bit better than they did before. They've got some respiratory effort, and now we need to start looking at secondary priorities. Well, our secondary priorities actually come down to 5 things, and there's actually an excellent course that spends a lot of time talking about this. The course is actually called Stable. If you have the chance to attend, I would highly recommend it. But the title Stable actually stands for the acronym STABLE, and STABLE is sugar, temperature, airway, blood pressure, lab work, and emotional support. These are the next priorities after we've done our initial resuscitation of the neonate. So the next thing we want to do is we want to make sure that the neonate's got an adequate sugar, and if the patient doesn't have an adequate sugar, then we need to start the kid on D10. Remember that a normal sugar in a neonate is anything above 40. So if the neonate has a sugar less than 40, then we need to give them sugar. When we talk about temperature, we want to make sure that the kid is warm. Again, we want to make sure that we're continuously reassessing to make sure they stay warm. And when we talk about airway management, we want to continuously assess for airway distress. And if they're starting to get airway distress, then we need to manage their airway and we need to manage their ventilation. We also want to make sure that they've got an adequate MAP. Remember we said again that the normal MAP for a neonate is whatever their gestational age is in weeks. And if they don't have that, then we need to ask ourselves, why does the kid not have an adequate blood pressure? Is it because of the fact they've got a volume problem? Is it because of the fact they've got a cardiac output problem? And so on and so forth. The other thing that we want to do pretty early on is we want to get some lab work on our neonates. One of the things that we typically do for any kid who's had any moderate distress is we get something called an ANC, or an absolute neutrophil count, and we're going to use that with a normogram, which we'll talk about here in just a few minutes, to determine whether or not there's a likelihood that the child has sepsis. If we suspect that the child has sepsis, then the big thing we do for those kids is we usually start them on something like AMP and GENT. And then finally, the other thing that we need to do is we need to emotionally support the parents. They need to be brought into the loop on what's going on, what the priorities are, what we've done, and where we're moving forward. Okay, when we talk about common neonatal emergencies, some things that you may see, one of the things that you may see is GI problems. One of the more common reasons why a neonatal transport team might go out to get a neonate would be something like an omphalocele, gastroschisis, or volvulus, or intussusception. So let's just talk about each one of those things. Remember that an omphalocele is when the child is born and for whatever reason along their midline, somewhere around their umbilicus, their abdominal contents have actually grown outside of their body. So when you get there, they basically have what looks like an evisceration. When we talk about gastroschisis is essentially the same thing, but it's not on the midline. It's not around the umbilicus. So, for instance, it may be way over here in the right upper quad or way over here in the left upper quad, where they've got this growth of abdominal contents outside their body. You're going to treat this exactly the same way that you would treat an evisceration in an adult. You want to cover it with a moist dressing. You want to make sure that that dressing is warm, and we also want to make sure that we've also covered it with some kind of occlusive dressing as well, like foil or something like that. The big thing to remember with these kids is they're really, really prone to getting cold, so we want to be real cognizant about maintaining their temperature. When we talk about volvulus or intussusception, these are two different things. Volvulus is where we actually have a twisting of the intestines, and intussusception is where the intestine actually basically grows in on itself, like in the picture that you see there off to my side. Both of these issues are surgical emergencies that need to be managed. The big thing is we need to get these kids to a pediatric surgeon who can correct this. We want to watch their fluids and their electrolytes. We want to make sure that we're making strides to keep them warm. We want to keep them obviously NPO, so on and so forth. Now, some other things that you might see, some other GI problems, you might be called out to get a neonate who's been chronically ill for some period of time, and because they've been chronically ill and chronically hypoxic, they've actually developed something called NEC. NEC is necrotizing enterocolitis, and essentially what happens with NEC is the bowel becomes so hypoxic that all the aerobic germs and things that are normally supposed to be in your gut become replaced with stuff that's not supposed to be in your gut. As that stuff that's not supposed to be in your gut tends to translocate across the intestines into the blood vessels, we get sepsis. What we typically see with NEC is we'll see abdominal distension. A lot of times these kids actually have GI bleeding. We may see a fair amount of air in the bowel, and the picture that you see right above me, that's actually a picture of a baby belly from a baby that has NEC. When we talk about treatment for these patients, obviously you want to keep them NPO, support their hemodynamics and their electrolytes, and the other thing is we need to stick an NG or an OG tube down them before transport. And finally, when we talk about abdominal hypertension, it's the same issue we have in adults. Remember that whenever we're dumping lots and lots of crystalloid into patients, they're going to dump about 66% of that fluid into their interstitial space or into their intracellular space within the first hour or so after we give it. And one of the biggest places where we dump lots of fluid is in the abdomen, which is a confined compartment. There's only so much space in the belly. So this becomes even more paramount in kids. If we're just giving lots and lots of fluid with no good cause, we could actually cause enough fluid to be interstitially leaked into the belly that we basically cause a compartment syndrome in the belly. So we want to be watching for that, and we want to be doing what we can to avoid that as well. Okay, now let's talk about coanal or conal atresia. I guess it depends on which part of the country you're in, whether you call it coanal atresia or conal atresia, but it's essentially the same thing. Remember that the pathophysiology behind this disease is that an infant is born with a permanent bifurcation or a permanent bony structure in the back of their nasopharynx. You could see where this would obviously be a problem because we all know from PALS and from all the pediatric training we've had before that infants are obligate nose breathers. So for these kids, if they just have isolated conal atresia, if that is their only medical problem, then they'll actually do fine if we can put them in a position where they're going to breathe successfully through their mouth. However, if these kids are left in a normal position, a lot of times they'll have pretty significant respiratory distress. Well, so how do we figure out that a kid has this? Well, one of the easiest ways that we figure that out is if we've actually suctioned deep enough at birth. A lot of times when we suction really far into the back of the nose, as we pass our catheter back, we'll actually realize that we meet a resistance, and we'll recognize the fact that this child has conal atresia. A lot of times the other classic thing that you'll see with these kids is the kids are nice and pink when they're crying, but as soon as they're left alone, as soon as they are allowed to decrease their stimulation and decrease their activity, and they are just resting quietly, all of a sudden they turn cyanotic. So that's kind of the classic thing with conal atresia, is the kid who is pink when they're crying, but they're cyanotic when they're still and they're calm. So when we talk about treatment for these kids, the definitive treatment is going to be ENT management, which may include surgery. But for us in the short term, the big things that we want to do, the first thing we want to do is we want to position them appropriately. A lot of times, just positioning them on their belly or positioning them on a surface where their head is in a neutral position and facing down will be all that is necessary to maintain their airway. Sometimes just laying them on their side is enough to relieve it. But if neither one of those things work, then the next step up would be to try and put in an oral airway. And if an oral airway does not work, then finally we would be stuck with no other option but to intubate. And remember again that if it's just isolated conal atresia, if that's the only thing that's wrong with them, then it's not a lower airway problem. It's just an upper airway problem. So as long as we can circumvent the upper airway and give them another mechanism to get gas into their lungs, then they typically do fine. Okay, when we talk about aspiration pneumonia, the biggest reason why we would see aspiration pneumonia in a neonate is because of meconium aspiration. That's by and far the most common thing that neonates aspirate. When we talk about meconium, remember the rules from PALS and NRP are that if we have a child who's born who's got obvious meconium staining, we ask ourselves whether or not they're brisk. And remember, brisk is defined as they've got good flexion, they're crying, they're vigorous, heart rate's greater than 100. And if they are brisk, then typically all we need to do for those kids is manage them just like we'd manage any other kid. There's a very slim chance if they're brisk that they've had good aspiration down into their lungs and are thus going to get aspiration pneumonia. In contrast, if the kid when they're first born is very lethargic, very sluggish, is not flexed, is not pink, is not crying, and requires some aggressive management, including intubation and suctioning repeatedly to try and remove all that meconium from their lungs, then there's a high likelihood that this child is going to have a pneumonitis because of it, or a pneumonia because of it. So when we talk about the whole intubate, suction thing for meconium staining, the thing that is worth remembering is that even if you do this and you do this correctly, if the child has already aspirated a significant amount of meconium, then that child is probably going to be critically ill even once you've cleared all that meconium out of their lungs. So don't be surprised if once you clear all the meconium, the child is still hypoxic, the child is still in frank respiratory distress, and the child requires intubation. Now, the other big thing that goes with these kids is when they get this aspiration pneumonia, one of the big problems that they have a lot of times is persistent pulmonary hypertension, and we're going to talk about that in just a few minutes. Okay, another neonatal emergency that they may ask about on these exams is diaphragmatic hernia. And if you remember with the diaphragmatic hernia, the whole disease process, if you will, is that the neonate, while in utero, had a defect that caused the diaphragm to not completely form, and because it didn't completely form, it didn't completely isolate the abdomen from the chest, so as their abdominal organs grow, they start to grow into the chest as well. The big problem for these kids, you would think it sounds pretty simple. You would think that, okay, it's pretty easy. We take them to the OR, we move all the stuff out of their chest, and we close their diaphragm. Unfortunately, it's not, because the other problem that happens to these kids is while all this abdominal organ is growing into their chest, what's not growing is the lung on the affected side. So, for instance, if they have a left diaphragmatic hernia, then we expect to see hypoplasia of that left lung. So basically that left lung is essentially not going to exist, or if it does exist, it's going to be very, very small. Because of that, these kids are in frank respiratory distress. Usually when they're born, they almost always have to be intubated. We have to put them on positive pressure ventilation. Remember that when you're assessing tidal volumes for these kids, because we typically pressure ventilate, so we're going to watch our tidal volumes, remember that they're going to be exhaling small tidal volumes because they've only got one full lung, and then on the other side they've only got part of a lung or a much smaller lung, so they're not going to be putting out the tidal volumes you would expect of a full-term healthy neonate. Now, other things that we need to do for these kids, obviously, if we're going to be transporting them, if we're going to be taking them up in the air, then we need to stick an NG tube down them or an OG tube down them fairly early. The other thing is, obviously, we want to keep them NPO. We don't want to put anything in their stomach or their intestines, because that's just going to leave even less space in their chest for them to breathe. And again, these are another subset of kids who end up with persistent pulmonary hypertension. Okay, now when we talk about respiratory distress syndrome, or the other name that you'll hear people use a lot of times is hyaline membrane disease, remember that RDS in infants is basically the same thing as ARDS in adults. It's very similar in etiology. Remember that with ARDS, the whole problem is they have a non-cardiogenic pulmonary edema. That pulmonary edema is caused by a breakdown in the capillaries that surround alveoli, and as those capillaries break down, all the stuff that's in blood vessels that normally holds oncotic pressure in place is leaked out into the interstitial fluid, and the interstitial space becomes congested with water, and as that water starts to build up, it helps to collapse alveoli, and then the other thing that starts to happen is we start to wash out surfactant. Well, with RDS in infants, it's very similar, the pathophysiology behind it, and the one thing that is really definitely a contributing factor with RDS in infants is the lack of surfactant. And when we talk about who gets RDS, it's pretty simple. The more premature the baby, the higher the likelihood that they're going to have respiratory distress syndrome. When we talk about mortality, we can even collate respiratory distress syndrome mortality with again, how premature the baby is. Excuse me. When we talk about the onset, usually these kids, when they're very first born, start to have respiratory distress very quickly after their birth. Usually they're in pretty significant respiratory distress somewhere about 3 to 6 hours after their birth. And we said that there was a direct relationship between RDS and prematurity. When we talk about the treatment, it just depends on how bad the RDS is as to how aggressive we're going to get. If the RDS is relatively minor, in other words, if the child is pretty close to term, sometimes these kids can just be managed with CPAP or with bubble CPAP. If that doesn't work, then obviously we're going to have to intubate the child, and usually if a kid is sick enough that they need to be intubated for RDS, then the other thing that we usually have to do is give them surfactant, and we give that surfactant down the ET tube. And then the other thing we do is we typically manage these kids prophylactically with antibiotics. And basically the treatment of RDS is just like the treatment of ARDS in adults. It basically boils down to we're going to have to provide mechanical ventilation with enough quality to provide enough oxygenation for a long enough period of time for those membranes to reconstruct and to rebuild. And if we can pull that off, if we can do that, then they're going to survive. If we can't pull that off, if their disease process is so bad that we can't adequately oxygenate them with enough quality for them to be able to heal, then they're going to die from the disease. Okay, when we talk about air leak syndromes, this is another thing you'll hear talked about all the time in the PICU and the NICU. The big thing to remember about air leaks is all an air leak is a pneumo something. It's just for whatever reason in the peds literature we tend to call it an air leak syndrome instead of calling it like a pneumothorax or a pneumomediastinum or whatever. But air leaks are typically caused in small kids by the fact that they've been intubated and they've been on high levels of positive pressure, and because of the incomplete development of their lungs or of their interstitial space or of their mediastinal space, then air is allowed to leak in and it traps, and we end up with a presentation that's just like what we would see as a pneumothorax or a pneumomediastinum or something like that in an adult. The big things that would tip us off that a kid is getting an air leak would be things like increases in the peak inspiratory pressure, when we have to keep bumping up our PIP in order to be able to adequately oxygenate and ventilate the kid, and also when we start to see decreases in perfusion. When we talk about management of air leaks, we'd manage an air leak in a peds patient just like we would manage an air leak in an adult, i.e. a pneumothorax or a pneumomediastinum in an adult. If the child is relatively symptom-free, then a lot of times we'll just watch it, but if there is symptoms that would suggest to us profound decompensation, then we need to go ahead and needle that air and aspirate it. So we would needle those children just like we would needle an adult. We could use like the second intercostal space in the mid-clavicular line, or we could use somewhere around the fourth to fifth intercostal space on the anterior axillary line, and we are going to aspirate that air out with a syringe. And a lot of times these kids end up buying a chest tube just like an adult would buy a chest tube if they had a pneumo. Okay, when we talk about pulmonary hypoplasia, that's another thing that you just need to know what it is and know a little bit about it. Pulmonary hypoplasia occurs when kids are born with lungs that aren't completely developed. It a lot of times coexists, like with RDS. The big thing to remember is that as fetal lungs develop, basically, if this is my lung and this is my blood vessels, i.e. if this is my alveoli and this is my capillaries that normally go around alveoli, as I develop in utero, those two things come together until eventually when we come out at term, those two things are right up against each other, just like they are in somebody who's an older patient. Well, with pulmonary hypoplasia, what's happened is the child is not, for whatever reason, developed all the way down to where the alveoli have actually come in contact with the capillaries. And obviously, the farther the relationship between those two, the more severe the disease is going to be. The big thing that we usually see with these kids is if it's pulmonary hypoplasia in one lung, usually the lung on the affected side looks very, very white because we're not having a lot of air enter. The other thing that we'll usually see is a lot of times we'll see that the trachea is actually deviated towards the affected side instead of being deviated towards the trachea will be moved towards the affected side. Unlike with a pneumo where you would expect to see that the trachea was deviated in the opposite direction. So again, you know that with a pneumo, just like you've always been taught with adults, if they've got a pneumo on this side, then the trachea is going to deviate this way. Well, with pulmonary hypoplasia, if the effects are on this side, then the trachea may deviate to the same side. When we talk about treating this, obviously the big thing we're going to do for these kids is we're going to treat their hypoxia as best we can. Obviously, we're going to start by giving them oxygen. If that doesn't work, then we're going to move up to CPAP or bubble CPAP. If that doesn't work, then we're going to go to intubation. A lot of times we give these kids surfactant as well because a lot of times, again, that kind of coexists with the whole RDS syndrome. If that doesn't work, then a lot of times what we end up having to do for these kids is put them on high-frequency ventilation or actually even put them on ECMO and give them time for that system to continue developing until we have a close relationship between the capillaries and the alveoli. Okay, when we talk about persistent pulmonary hypertension in the newborn, we've already talked about that several times, but remember from our anatomy and physiology, if you've already listened through the cardiac lectures, we've already spent a significant amount of time in the hemodynamics section talking about the number one reason why pulmonary arteries vasoconstrict is because of hypoxia. And that's thought to be kind of like an almost self-protective thing. If I've got hypoxia in my lung because it's diseased up here, then all of the blood vessels that are going to that part of the lung are going to vasoconstrict, so the blood is shunted to other parts of the lung that are healthy. The problem is when the entire lungs are diseased, then everything vasoconstricts. All of our pulmonary vasculature vasoconstricts. Well, the big problem with persistent pulmonary hypertension is exactly that. You've got a child, an infant, who has some massive respiratory distress, and because of that massive respiratory distress and the chronic hypoxia that goes with that, they start to develop chronic persistent pulmonary hypertension. So once we fix the respiratory distress, if we haven't fixed it fairly early, if we don't fix it very quickly, what happens is they essentially build the musculature and build the nervous system is such that they just stay hypertensive in their lungs. And then we end up with persistent pulmonary hypertension that can continue even into adulthood. And the big problem, if you remember from persistent pulmonary hypertension in adults, is if they have pulmonary hypertension, that means that the right ventricle is constantly having to work harder to push blood into these vasoconstricted pulmonary arteries. Over time, that right ventricle starts to become bigger and bigger, and we end up with a cardiomyopathy on the right side. And for adults who have really bad persistent pulmonary hypertension, what ends up happening is a lot of times they need a heart and lung transplant, or else they'll end up dying of the disease. So with infants, what happens is that this persistent pulmonary hypertension actually causes their pulmonary vascular resistance to become higher than what their systemic vascular resistance is. And remember, when you're very first born, you still have several holes that still exist. One of the holes that still exists is you still got a foramen ovale. Remember, the foramen ovale is the hole that separates your right atrium from your left atrium. Well, if your right atrium is now the higher pressure, if your right atrium and your right ventricle have become higher higher pressure than the left side because of persistent pulmonary hypertension, well then blood is going to shunt from left to right. And so we end up with all kinds of problems, blood is going to shunt from right to left. And so we end up with all kinds of problems related to the fact that blood is being moved, unoxygenated blood is being moved from the right side of the body to the left side of the body to be distributed out to the body. So they end up with really, really frank hypoxia, and they end up with really, really poor oxygenation and O2 sats. When we talk about the ways that we treat persistent pulmonary hypertension, the very first thing is we said the number one reason why kids get pulmonary hypertension is because they're hypoxic, so obviously we want to treat the hypoxia. That's like goal number one. We want to make sure that we adequately oxygenate these kids well. The other thing that we can do to help limit pulmonary hypertension is we can actually make sure that we sedate and paralyze these children. A lot of times just the sedation and the paralysis alone will be enough to cause some dilation of the pulmonary arteries. Other things that we can do for these kids, a lot of times keeping them alkalotic, keeping their pH between like 7.45 and 7.55 will help to ease up some of that pulmonary hypertension. If that doesn't work, the next thing that we'll typically do for these kids is we'll go to giving them nitric. By giving them nitric oxide, remember nitric oxide is a vasodilator, and so by adding nitric oxide to their ventilator gas that they're inhaling, we can directly attack those pulmonary arteries themselves and try and get them to vasodilate out. If that's not working, or at the same time, some other things that we might try and do from an IV perspective is we may try and actually give them calcium channel blockers, or the other medication that we'll give them is Viagra. And if that doesn't work, then the other thing we need to do for these kids is we need to put them on ECMO, and if they're going on ECMO, they also need to be anticoagulated. So again, this persistent pulmonary hypertension thing is a really big deal a lot of times in pediatric critical care, or specifically in neonatal critical care. So remember, there's several things we said that we can do to decrease pulmonary vascular resistance. And just to hit the high points again, because it's important, you really need to understand this concept. Whenever we've got persistent pulmonary hypertension and we want to decrease the hypertension in the pulmonary arterial system, the very first thing we do is we add oxygen. If that doesn't work, then the next thing that we do is we sedate and we paralyze. If that doesn't work, then what we do at the same time is we also make these kids alkalotic. And so a lot of times what we'll actually do is we'll hyperventilate them and we'll actually give them bicarb to purposely make them alkalotic. And then finally, if that doesn't work, then the next thing we do is go to nitric. So again, first thing is give them oxygen. If that doesn't work, sedate and paralyze. At the same time, hyperventilate, and if necessary, give them bicarb to make them alkalotic. And finally, we transition to nitric. And most of the time, that's what we have to do for these kids. It's only when they fail all those other things that we start looking at doing things like putting them on ECMO. Okay, when we talk about neonatal sepsis, remember that when we talk about neonatal sepsis, most cases of neonatal sepsis actually occurred when the baby was still in mom. The baby was exposed to something, and so when they were exposed in mom, they started this infectious process that becomes evident to us after they were born. Some common things that would make us suspect that a neonate might have sepsis are things like premature ruptures of membranes. We can see it in moms who've had a UTI fairly close to when delivery occurs, or the other place where we see this is in kids who get group B strep because mom had streptococcus in her vaginal canal. A lot of times, the way that this actually manifests itself in a neonate is actually very similar to meningitis, or it may actually be as meningitis. The other thing that can happen is this can present looking like respiratory distress. We can have a neonate who's in sepsis who looks like they're in respiratory distress. And that's why all these respiratory distress things that we've talked about, several times you've seen where we've said, and we're going to put them on antibiotics, and we're going to put them on antibiotics, because early on that differential can be really difficult trying to figure out whether a neonate is in true respiratory distress or whether they're in sepsis. So we kind of just attack both things right off the bat until we can get a better hold on what's really going on and make a determination, yes, this is or is not yes or no, this is not sepsis, or yes or no, this is truly a respiratory problem. When we talk about the treatment for these kids, kids with neonatal sepsis, obviously the first thing we need to do is, like any other patient, we need to focus on the ABCs. If they're in ventilatory failure, obviously get them intubated, get them on mechanical ventilation. When you look at circulation, just like anybody else, think about the 3 things that make circulation. Do they have adequate volume? If not, fluid resuscitate them. Do they have adequate cardiac output? If not, put them on pressors. And finally, do they have adequate squeeze? If not, then we need to put them on vasoconstrictors. When we talk about identification of neonatal sepsis, the big thing that we use is something called the ANC, which is the absolute neutrophil count, and we actually have normograms that will show us what the absolute neutrophil count should be based on how old the child is, and the diagram above me is a good example of a normogram for absolute neutrophil counts. If the child falls within certain parameters, then we would say that it's highly likely that that child has sepsis, and so then we would start that kid on AMP and Gent, and that tends to be the most common thing. Remember that before you start them on antibiotics, you want to get cultures for everything. So you want to culture everything you possibly can, culture their urine, culture their blood, culture their sputum, so on and so forth. And then the big thing we do for neonates with sepsis is fluid resuscitate them. A lot of times they respond much better to treatment for their sepsis than an average adult would respond to treatment for their sepsis. A lot of times identifying the offending organism and getting the appropriate antibiotics on board while fluid resuscitating these kids and supporting their ABCs is enough to get them through their sepsis. Okay, when we talk about cardiology, we're going to wrap up our ped section here by talking just for a few minutes about a couple of different types of cardiology emergencies. And before we talk about cardiology, we need to kind of review fetal circulation. Remember that when a fetus is sitting in mom, most of its oxygenated blood is actually coming from the placenta. Well, actually, all of its oxygenated blood is coming from the placenta. And remember that the placenta attaches to baby in the form of an umbilical cord, and that umbilical cord actually ends up connecting to the baby down along their lower venous system in their abdomen. Now, as all that excess blood that's coming from the placenta back towards baby is entering the venous system, what we actually see when we're in utero is that our right-sided heart pressures are actually higher than our left-sided heart pressures. So we know that when you're an adult walking around in the world, we know that your left ventricle and your left atrium have higher pressures than your right ventricle and your right atrium. But not so when you're a fetus. When you're in mom, actually the higher pressure's on the right side. And because the higher pressure's on the right side, most of the blood that comes into the right atrium is actually pushed straight across the right atrium into the right ventricle through a hole that's called the foramen ovale. And the foramen ovale, again, it's this hole that just sits right between the right atrium and the left atrium, and it actually has a flap on it. And that flap is designed to flap close and shut it whenever there's higher pressure on the left side. When there's higher pressure on the left side, that flap closes and it closes our foramen ovale. But again, remember that when we're in mom, the right side is the higher pressure. So that higher pressure pushing through the hole is actually keeping the flap open. Now, there's some blood that doesn't make it straight across, and that blood that doesn't make it straight across is squeezed out of the right atrium down in the right ventricle, and as the right ventricle squeezes, it pushes blood up into the pulmonary arteries. But remember, we said that the number one reason why pulmonary arteries constrict is because of pulmonary hypoxia. Well, when you're sitting in mom, you're not breathing through your lungs, so your lungs don't have any oxygen in them. So while the right ventricle is pushing blood up into the pulmonary arteries are basically closed because there's no oxygenation in the lungs. But remember that there's a connection between the pulmonary artery and the aorta, and we call that the ductus arteriosus. And so as the right ventricle contracts and it pushes blood up into the pulmonary artery, the blood realizes that it can't continue to move down the pulmonary arteries because they're closed off. So really it has no choice but to go up the ductus into the aorta and to be circulated around to the body. And that's okay because it's already been oxygenated by the placenta. So that's normal physiology when we're sitting in mom. Now when we talk about neonatal distress, one of the first things that we have to deal with when we have a baby who's first been born and all of a sudden is not doing well is whether or not that child has a respiratory disease or cardiac disease. Those are the two most common reasons why we would have a neonate who's in trouble. So what types of things would suggest to us that it's respiratory? Well, the very first thing that would suggest to us that it's respiratory is if it's present at birth. Remember that when we talk about cardiac defects in kids, a lot of times the kind of central thing that creates problems, if you will, is when the ductus starts to close. And we normally see that the ductus starts to close within the first few hours of life, and it's basically functionally closed by like the end of the first 24. Well, with respiratory problems, if they've got something like pulmonary hypoplasia or they've got something like diaphragmatic hernia, well, as soon as they're born and they make the transition to trying to breathe through their lungs, they're going to have problems. So a lot of times we'll see respiratory distress as an almost instantaneous thing after the child is born, whereas our cardiac stuff, a lot of times we won't see problems until several hours after they're born. The other thing is if we have prematurity suggests that it's probably more likely a respiratory problem. Remember we said RDS was related to how early the baby was. So if you've got a baby who's really, really premature and as soon as they're born they start to have respiratory problems, that suggests to us RDS. It's not always, but suggests to us that it probably is respiratory. Some other things that would suggest to us that the kid has probably got a respiratory problem and not a cardiac problem. Another good one would be meconium aspiration. If we've got meconium aspiration, then obviously the big thing we're worried about is the child having aspiration pneumonia, and that would probably be our most likely differential diagnosis first off. Something else that may tip us off that there's more likely a respiratory problem than a cardiac problem would be if the baby was born by C-section. Remember that as the baby is born, as the baby is pushed through the vaginal canal, there's a whole bunch of pressure that's being pushed in on its chest. And all that pressure being pushed in on the chest actually helps to remove a lot of the amniotic fluid that's normally sitting in the lungs when the baby's sitting in mom. When babies are born by C-section, they don't go through that same what we call transition like a baby would that was born by vaginal delivery. So a lot of times they end up with more pulmonary edema, they end up with more respiratory problems, at least early on, than a child who's born by vaginal delivery. Some other things that we want to think about, if the kid has a respiratory problem, and they've got hypoxia, but we put the kid on O2 and they get better, then that would suggest to it's a respiratory problem. And that's actually the focus of what a shunt study is. When we do a shunt study, basically what we do is we put a kid on oxygen and we figure out when we put them on oxygen, does it improve their oxygenation? We draw blood gases and see, does it make things better or not? If we put a kid on oxygen and their shunt study shows that their PaO2 and their SaO2 go up, then we would say that the kid had a positive shunt study, and that suggests respiratory problems. If we put the kid on O2 and it goes down or it doesn't change at all, then that's a negative shunt study, and that a lot of times suggests to us that they've actually got a cardiac problem. Now, when we talk about cardiac problems, some other things that would tip us off that it's a cardiac problem. Remember we said again the onset. We said usually with cardiac problems they're a little bit slower in onset than respiratory problems. So some of these kids, they may not have immediate respiratory distress as soon as they're born. We'll see instead that they start to get respiratory distress several hours or even several days after they're born. The other thing is if the child has a murmur. If you listen to the heart and the child has a murmur, that should definitely make you at least suspect that there may be some cardiac involvement. If the kid has hepatomegaly, if we can palpate their liver below their rib cage, especially the further down we can palpate it, the more that suggests that they've got CHF, and so the more that suggests that it's a cardiac problem. If we've got problems with crappy perfusion, that would tip us off that it's probably a cardiac problem. And also, if we've got shortness of breath, but the kid is not grunting or the kid is not retracting, that would also tip us off that it's probably a cardiac event. Now, when we talk about cardiac issues, we break down neonatal cardiac disease into what we call cyanotic and acyanotic disease. And this can be a little bit of a misnomer, because you can have a kid who's got cyanotic cardiac disease who's not very cyanotic, just like you can have a kid who's got acyanotic heart disease, but you look at them and they're very cyanotic. So it's kind of a misnomer. Really what the cyanotic versus acyanotic boils down to is whether or not the child has a ductal dependent lesion. So when we talk about cyanotic heart disease, remember that kids with cyanotic heart disease, they're dependent on ductal blood flow. And what is ductal blood flow? Well, remember we said that normally when the right ventricle contracts, when you're in utero, as blood is pushed up in the pulmonary arteries, because they're closed, that blood is pushed up through the ductus arteriosus into the aorta. So when we talk about the ductus, we're talking about that connection between the pulmonary arteries and the aorta. And kids who have cyanotic heart disease are dependent on that duct. As long as that duct stays open, they've got adequate oxygenation, or at least some level of oxygenation. When these kids get in trouble is when that ductus starts to close. And remember, we said that that ductus starts to close within the first couple hours after you're born, and it's completely closed functionally, it's functionally closed typically by the time you're about 24 hours old. Now with these kids, the big thing to remember is they have a right to left shunt, so they're moving blood from the right side to the left side. And we all know that blood on the right side once you're born is not oxygenated blood. So because of that, these kids have a huge mixing of unoxygenated blood with oxygenated blood. And the net result of that is that depending on how big their shunt is, we've got a significant drop in the pulse ox. A lot of times these kids live with pulse oxes in the range of like 75 to 80%. And the classic telltale thing that we see with cyanotic heart disease is the number one thing that causes the ductus to close, one of the biggest stimuluses that causes the ductus to close, is the presence of oxygen. The more oxygen there is, the faster the ductus closes. So with these kids, the big thing that we see is when we put them on oxygen, because they're hypoxic, and that's what we do for kids who are hypoxic, the oxygen actually makes them worse. It actually accelerates closure of the ductus. So the big thing for these kids is we actually don't want them to be on oxygen. We want to get the oxygen off of them. And when we talk about what we're going to do for kids who have cyanotic heart disease, the big thing to remember is the drug of choice for cyanotic heart disease is something called prostaglandin, or PGE1. And prostaglandin actually helps to maintain that ductus open. As long as we've got the kid on prostaglandin, the prostaglandin is going to help to maintain an open patent ductus. In contrast, when we talk about kids with acyanotic heart disease, they're typically not ductal dependent. Their big thing is they've either got a problem with inflow or outflow of the ventricles. So there's either a problem with getting blood into the ventricle, or there's problems with getting blood out of the ventricles. Because of this outflow or inflow problem, what happens is blood backs up. And depending on where the obstruction is going to depend on where the blood backs up to. For instance, if they have an outflow problem in their right ventricle, then their blood is going to back up systemically. In contrast, if the inflow problem is on the left side of the heart, then what's going to happen is the right ventricle is going to continue to push blood into the lungs, but because it can't get into the left side of the heart, it's going to back up into the lungs, and we're going to get CHF. When we talk about these kids, their big problem is they actually have a shunt the other way. They have a left to right shunt. They actually have a movement of blood from the left side of the heart to the right side of the heart. And so it's exactly opposite of the cyanotic heart disease kids who have a right to left shunt. Now with the acyanotic kids, the big things that we see with them is we see lots of CHF and failure, and the other thing that we see lots of is persistent pulmonary hypertension. Okay, now when we talk about neonatal CHF, we can see neonatal CHF with either one, with cyanotic or acyanotic heart disease, depending on what the defect is. But by and far, we see a lot more neonatal CHF with acyanotic heart disease than we see with cyanotic heart disease. When we talk about the presentation, the typical way that we figure out that a neonate is short of breath would be, or that a neonate has CHF, is that they're short of breath with an exertion. And remember that the exercise of the infant is eating. So the very first place where we really see kids get short of breath is when they start eating. That eating requires a lot of work when you're an infant. And because of that, that's where we start to see that they get short of breath. And so what do they look like when they're short of breath? Well, guess what? They look just like what adults look like when they're short of breath. A lot of times they'll get really, really sweaty. They may get pale or gray. When you listen to their lungs, you may hear crackles. They may have hypoxia. And again, the big thing we look for is that hepatomegaly, or that big, huge liver. It's just like the way that CHF presents in adults. Now, when we talk about the management of CHF in kids, the first thing that we do for kids is we give them oxygen, just like if we would give, just the same way we would give an adult who had CHF and was in respiratory distress oxygen. Now the one thing is, remember again, we want to know whether or not they're ductal dependent. If they're ductal dependent, remember oxygenation is going to make them worse because it's going to close the ductus. So ideally, if somebody's already done an echo and we know that they've got a PDA, a patent ductus arteriosus, and they're dependent on that PDA, then we would not want to give them oxygen. But if we don't know, or if we know that it's not a ductal dependent lesion, then we do want to give oxygen. And remember, again, it's just like every other treatment you've ever been taught about in school. If you start a treatment for a patient and it makes them worse, then stop it. If you've got a kid who's hypoxic and you put them on oxygen, and you note that when you put them on oxygen they get more hypoxic, then they're probably ductal dependent. We probably need to stop the oxygen. The other things that we want to think about, a lot of times what we'll do for these kids is we'll give them morphine to vasodilate them out. A lot of times we give them Lasix to diurese them. If the kid has got, if their CHF is caused by poor contractility, we may actually use digoxin to help improve some of their contractility. And we also use drugs like dobutamine, epinephrine, and phosphodiesterase inhibitors for the same reasons, all because of the increase in contractility. And in adults, there's been a big push away from using contractile drugs in CHF because it actually creates something called ventricular remodeling, because adults typically, when they have CHF, they've also got years of coronary artery disease, and they don't have healthy coronary arteries that can support that workload by the heart. But that's not so in kids. Usually when kids are first born, they've got nice healthy coronary arteries that don't have 30 years worth of McDonald's in them. So those kids actually can stand the chronotropic effects that we would get by giving them dobutamine or epi or a phosphodiesterase inhibitor. Okay, so let's look at some of the actual defects themselves before we wrap up here. One of the defects that we can actually have is something called patent ductus arteriosus, or an isolated PDA. When a kid is born and they have an isolated PDA, what that means is that there's nothing wrong with their heart. They're absolutely fine, except for the fact that their ductus just fails to close. Well, remember that the whole purpose of the ductus was to push blood from the pulmonary arteries up into the aorta, because when you're in mom, the right side of your heart and your pulmonary system have a lot higher pressure than the left side of your heart and your systemic system. But once we're born, remember, that process reverses itself. All of a sudden, when we cut off all that blood flow from the placenta, now the right side and the lungs are lower pressure than the left side in the systemic circulation. So you can see where this would be a problem, because if I've got nothing wrong with me except for the fact that this ductus just fails to close, well, every time I eject blood out of my left ventricle into my aorta, some of that blood is going to take the path of least resistance, which is down the PDA back into the lungs. So we actually have blood flow going the wrong way. We have blood flow going from the aorta into the pulmonary artery. And the big problem with just an isolated PDA is that these kids overflood their lungs, and by overflooding their lungs, it puts them into CHF. So we're going to manage their CHFs just like we talked about. Now, if the kid has an isolated PDA, then typically the drug of choice is indomethacin. They'll put them on indomethacin to accelerate closure of the PDA. But remember again that if we want to keep that PDA open, in other words, if the kid's got a really sick heart and we need that PDA, then we said the drug to keep the PDA open was prostaglandin. So indomethacin is what we use to close the PDA. Prostaglandin is what we use to keep the PDA open. Now, for kids where we want to close their PDA because there's nothing wrong with them but the fact that they've got this PDA that's open, the other thing that they'll do for these patients is they'll take them to the OR and they'll actually coil them, which is where they basically tie it off. And remember that oxygen administration is one of the strongest things that we can do to accelerate closure of the ductus. So if we've got a kid who's got an isolated PDA and nothing else wrong with them, then giving that kid oxygen is going to be beneficial. But remember again, if the kid had cyanotic heart disease, then the thing that's keeping them alive is keeping that PDA open. And in that kid, you certainly wouldn't want to give that kid lots more oxygen. Okay, when we talk about transposition of the great vessels, this is another problem that we could see, another example of a fairly common heart defect. This is a great example of a cyanotic heart disease. This is a great example of a kid who has a ductal dependent lesion. So with transposition of the great vessels, the whole issue is that when your heart is forming, basically your aorta and your pulmonary artery end up in the wrong places. Your aorta ends up coming out of your right ventricle, and your pulmonary artery ends up coming out of your left ventricle. And you can see where that creates just a little bit of a freaking problem. Because if I have blood go from my right atrium to my right ventricle to my aorta and back to my right atrium. Meanwhile, over here on the other side, I've got blood going from my left atrium to my left ventricle to my pulmonary artery and then back to my left atrium. Well, obviously I've got a huge problem because I've got basically two concentric circles of blood that are not exactly helping me. I've got really good oxygenated blood over here, but out here where my body needs it, there's no oxygenation. Well, this is a great example of a ductal dependent lesion because when this kid is first born, the thing that's keeping him alive, the thing that's saving his life, is the ductus being open, because when the ductus is open, it creates a communication path between the pulmonary artery and the aorta. And because of that, that allows for some mixing of oxygenated and unoxygenated blood. But as soon as that ductus closes, that kid starts to suffocate. So we want to keep this ductus open. So the other thing that helps with this, the other thing that kind of helps to allow for some mixing of blood is because of the pressure gradient changes. A lot of times these kids will have a patent foramen ovale, and so we've basically got those 2 points where blood is mixing, and as soon as we lose those 2 points, as soon as the foramen ovale closes, as soon as the ductus closes, we suffocate and we die. So when we talk about the presentation for these kids, the big thing that you'll see with these kids is that as they continue on in their first 24 hours and that ductus starts to go through its normal closure period, we'll see that they'll become progressively hypoxic, and these kids will end up presenting exactly like a kid who's got cyanotic heart disease. We'll see their O2 stats will fall, we'll see that their cardiac output is poor, we see that they get gray, that they get mottled, or they get really, really blue. Oftentimes they'll get blue instead of getting gray, and these kids are obviously in significant distress. When we talk about other issues regarding this, remember that these kids, a lot of times that patent foramen ovale will stay open for some period of time, so we want to be really cautious about making sure that they don't get any air in their lines. And the big thing we need to do for these kids is we need to put them on prostaglandin. They need that prostaglandin to survive until they can get to the OR and actually switch the connection points of those two great vessels. So we put them on prostaglandins, and if you've never given prostaglandins before, the one thing you need to know about prostaglandins is that they tend to cause either apnea or hypoventilation. So in the ICU, in the pediatric ICU, we'll start kids on prostaglandin all the time and just watch them really close. But it's pretty much agreed on in transport medicine that from a transport perspective, if you're going out to get a kid who's got a ductus that you need to keep open with prostaglandin, because of that nasty side effect, we usually intubate those kids before transport. Now, once we've got them intubated and we start them on the prostaglandin, remember again, you want to keep their oxygen levels low. And when I talk about oxygen, I'm talking about the FiO2. You want to keep the FiO2 low. Remember that the higher you make the FiO2 on the vent, the more they're going to close their ductus. The other things that are going to be done definitively for these kids once we get them to where they're going is they're actually first probably going to go in and create a VSD so that there's again a place for mixing of blood, and then finally they'll take them to the OR and actually do something called a Jantine procedure, which is where they actually switch the position of the aorta and the pulmonary artery. Okay, when we talk about a ventricular septal defect or a VSD, this is something that we see a lot. It's probably one of the more common things that we see when we talk about pediatric cardiology. And the big thing about VSDs that you want to know is this is a good example of an acyanotic heart disease. With VSDs, it depends on the size and the location, whether it's a little deal or a big deal. When we talk about a VSD, we know that that's just a hole between the right ventricle and the left ventricle, and we can have anywhere from one teeny tiny little hole, which is not a big deal at all, and a lot of times we'll do nothing for, up to we could have multiple really big holes, or really have one functional ventricle, because there's so many holes between the right and the left that they basically are really just operating as one. When we talk about VSDs, the big thing that you'll see with these kids is a lot of times they have a murmur, and the louder and the more high-pitched the murmur is, the better, because that tells you the more turbulent the blood flow is, and we know that the more turbulent the blood flow is, the smaller the hole is. Now, the majority of VSDs actually close on their own, but if it's a big VSD, it may not close on its own, and if it's a big VSD, the big thing that it can do is it can cause CHF. Remember, the mechanism for that is because the left side is higher pressure than the right side once you're born, because you've got this hole in the middle. Every time your heart contracts, some blood is going to be pushed push from the left side back to the right side. The right side is always trying to keep up with that, and it's constantly overflooding the pulmonary arteries, and thus the kid gets CHF. And we already talked about what CHF looks like and how to manage it. When we talk about the treatment for these kids, it's basically the treatment for CHF. Again, give them oxygen. We can give them morphine and Lasix, things like that. And if they have contractility problems, or we want to improve their contractility, then we can do that with drugs like DIG or dobutamine or drugs like that. And when we talk about the definitive treatment, they're actually going to go and they're going to put in something called a patch, and the patch actually just goes over the VSD and closes it if it's something that requires operative intervention at all. Okay, when we talk about coarctation of the aorta is another example of a disease that's caused because of an ineffective movement of blood through the system. It's caused by a backup. So what happens with coarctation is when the kid is born, or as the kid's aorta is developing, what happens is there's just this part in the aorta where all of a sudden it narrows down really, really small, and then it grows back out into a big aorta again. Well, we all know from hemodynamics that Plumbing 101 says that anytime I'm trying to push fluid through a smaller space, then fluid is going to back up. Well, that's exactly what happens with the coarc. So how do we identify a coarc? Well, the big way we identify coarcs is we actually do blood pressures and pulse oximetry on all four extremities. And depending on where the coarc is, we'll typically see that there'll be a gradient between what we see in front of the coarc and what we see past the coarc. So for instance, if the coarc is past our left subclavian, what we would see is that we would have great pulses, great pulse oxes in our upper extremities, but yet we would have crappy pulses and crappy pulse oxes in our lower extremities. In contrast, if the coarc was more medial, if the coarc was, say, between the left subclavian and the right subclavian, then what we would see is that the right side would look great, the right hand would look great, good pulse ox, good pulses, good blood pressures, but the left hand and both lower extremities are going to have poor pulse oxes and poor blood pressures. Now, when we talk about the backup, obviously the fluid, because it's under constantly high pressure, trying to move through this little tiny hole, is going to back up in the left ventricle, and given time, it's going to back from the left ventricle into the left atrium, and then obviously eventually it's going to back up into the lungs, and the kid is going to present with, guess what? CHF. So we're going to treat these kids like we're going to treat any other kid that's got CHF. Okay, when we talk about tetralogy of Fallot, this is another one of our top 5 pediatric cardiology issues that we deal with from an emergency perspective. Tetralogy of Fallot kids actually have 4 different problems going on. The first thing that they have is they've got a huge VSD. They've got a big hole between their right ventricle and their left ventricle. The second thing that these kids have is they actually have a pulmonary artery outflow problem. So their big hole between the right ventricle and the left ventricle is so big that basically it just means they've really got just one ventricle. Functionally, the right ventricle and the left ventricle are basically functioning as one. Now, because they're functioning as one, every time they squeeze, blood is going to go one of 2 places. It's going to go up the pulmonary artery or it's going to go up the aorta. But because we have a pulmonary artery outflow problem, where do you think most of the blood is going to go? It's going to go out the aorta. So we end up pushing more blood out of the aorta than we do out of the pulmonary artery. And because of that, these kids get cyanotic. They get cyanotic heart disease. When we talk about the other things that happen with tetralogy of Fallot, these kids also have a right ventricular hypertrophy that occurs. The right ventricle becomes really, really big because the right ventricle is trying to keep up with the left ventricle. And finally, the last thing that we see is that these kids have rightward displacement of their aorta. So these kids actually have what's called dextropositioning of their aorta, which means their aorta has been moved over to the right, which actually means that it sits right above the VSD. So not only is the aorta getting preferential blood flow because of the fact that the pulmonary artery is hard to push blood through, but the aorta is also even sitting in a place where it's perfect to get lots and lots of blood flow. So what happens with these kids? Well, the big thing that happens is when that pulmonary artery spasms down, or depending on how bad the pulmonary stenosis is in the pulmonary artery or in the pulmonic valve, they tend to get lots and lots of hypoxia. Now, one of the things that these kids are really prone to getting is actually something called a hypercyanotic spell, or a lot of times you'll hear people call them TET spells. And this is a sudden onset where the kid has a spasm of their pulmonary artery, and while they normally have crappy blood flow through their pulmonary artery anyway, when this pulmonary artery spasms, the blood flow through the pulmonary artery gets really bad. So basically all their blood is being pushed out through their aorta and very little is being pushed through their lungs for oxygenation. So with the hypercyanotic spell, what happens is the kid turns blue, the kid gets tachycardic, then bradycardic, the kid acts exactly like a kid would act who has sudden onset hypoxia. When we talk about the management for TET, these kids a lot of times are ductal dependent, so what that means is that they need to go on prostaglandin. A lot of times we need to minimize the amount of O2 that we give these kids to keep the ductus open. When we talk about the definitive management, they're going to go in and they're going to surgically manage all this. First, they cath the PA and they dilate it out. Then they patch the VSD, and those kids typically do fine after that. But again, during that immediate period, the big thing we're watching for is the hypoxia that comes with that inability to push blood in the pulmonary artery, and especially when they have these hypercyanotic spells or TET spells because of spasm of the pulmonary artery. Now, when we talk about those hypercyanotic spells, you need to know what to do to manage them. And there's really just a couple of things that we need to do. If the kid has a hypercyanotic spell, the very first thing that we would like to do for this kid is get this kid to lay down and put them in a knee-chest position. By putting them in a knee-chest position, we basically bend their femoral arteries and increase their systemic vascular resistance. By increasing their systemic vascular resistance, that essentially forces more blood up their pulmonary artery. The other thing that we usually do at the same time is give these kids oxygen unless we're trying to keep the ductus open. And the other thing that we will do for these kids is we will actually give them morphine. Morphine helps to vasodilate the pulmonary arteries, and a lot of times that will relieve these hypercyanotic spells. Okay, last but not least is hypoplastic left heart. This is another one of our top 5 big things that we have to deal with from an emergency perspective with regard to neonatal cardiology. With hypoplastic left heart, of all the pediatric heart diseases to have, this is probably like the worst one to have. This is not a good time. Kids with hypoplastic heart disease are critically ill. So when we talk about kids with hypoplastic left heart, remember the whole issue here is that as these kids grow and develop, everything grows and develops fairly well except their left ventricle. Their left ventricle can be either really small, or in some of these kids it's so bad that it's basically non-existent. They basically don't have a left ventricle. And because they don't have a left ventricle, all the blood that gets pushed from the lungs goes into the left atrium, and then because there's nowhere to go, because there's no real left ventricle, most of it gets pushed through the foramen ovale back to the right ventricle, back to the right atrium. So again, right ventricle pushes blood up into the lungs. As that blood in the lungs dumps into the left atrium, because there's no left ventricle, the left atrium has no ability to do anything but push it back across the foramen ovale back into the right atrium. So these kids are definitely kids who have cyanotic heart disease. The other thing with these kids is they are very ductal dependent. So we definitely want to make sure that these kids have an open ductus. Now, once that ductus starts to close is when we really start to see our emergency. So usually kids with hypoplastic left heart present within the first 24 hours. And the way they present is they start to get mottled. A lot of times they'll get gray or they'll get cyanotic, and we'll see that their pulse oxes will drop significantly. A lot of times these kids live with pulse oxes in the 70s to 80s. Now the big thing to remember with these kids is we want them to stay ductal dependent in order for them to be able to mix blood. And so you look at that pulse ox in the 70s or 80s, and the first thing you think that you want to do for these kids is actually to give them oxygen, but actually that is the worst thing that we can do for somebody who's got hypoplastic left heart. The last thing we want to do for a child with hypoplastic left heart is give them oxygen. So when we talk about management of these kids, again, these kids need ABC management. Almost always kids with hypoplastic left heart, in fact, I could probably say always kids with hypoplastic left heart are going to require intubation mechanical ventilation. A lot of times what we have to do for these kids is we have to drop the FiO2 so low that even room air isn't good enough. So a lot of times what we have to do is we have to bleed other gases into their ventilator so that we can drop their FiO2 to less than 21%. A lot of times these kids have to survive on O2 sats, or excuse me, on FiO2s of like 18-19% in order for that ductus to stay open and in order for blood to move the way that it's supposed to move. And then the other thing, obviously, in the emergent setting that we need to do for these kids is we need to get them on prostaglandins to keep that ductus open. So again, this is a very critically ill child, and when we talk about the repairs for hypoplastic left heart, it's actually done in 3 stages, and it's done over several years. So these kids are very critically ill and stay very critically ill for a significant period of time. Okay, that is the big things that I have there for you for pediatrics. I hope that this has been somewhat informational for you. Thank you for being with us today. My name again is Anthony Baca. If you have any questions, feel free to email me. My email address is abaca@camanagement.org. That's abaca@camanagement.org. Or you can find contact information for me on our website, which is www.camanagement.org. That's www.ca, as in clinical analysis, management.org. I hope that you have a great day, and thank you for being here.
I'd come for you, no one but you. Yes, I'd come for you, but only if you told me to.